Duchenne muscular dystrophy by Christina Rutten. What is Duchenne muscular dystrophy? According to MDA.org, Duchenne muscular dystrophy is a genetic disorder characterized by progressive muscle degeneration and weakness due to the alterations of a protein called dystrophin that helps keep the muscle cells intact. There are 4 conditions known as dystrophinopathies: Duchenne muscular dystrophy, Becker muscular dystrophy, an intermediate clinical presentation between DMD and BMD, DMD-associated dilated cardiomyopathy. Some signs and symptoms. Symptoms may vary person to person. Calf muscle hypertrophy, cardiomyopathy, cognitive impairment, delayed speech and language development, flexion contracture, global development delay, progressive muscle weakness, respiratory insufficiency, scoliosis, skeletal muscle atrophy, specific learning disability, or a waddling gait. Here's a picture of DMD in the clinical manifestations. As you can see, the shoulders and arms are held back awkwardly when walking. You may see a sway back, weak butt muscles, hip straighteners. Knees may bend back to take weight. You can see a thick lower leg muscles. The muscle is mostly fat and not strong. Tight heel cords, so the child may walk on their tippy toes. The belly sticks out due to weak belly muscles, so the child is poor at sit-ups. You'll see thin quads, especially on the front part, right here in the thigh. Poor balance, so they may fall often. Awkward, clumsy if walking. This is due to the weak muscles. They may also experience some foot drop and what they call tiptoe contractures. Now, the onset age is 3 to 6 years. Progressive weakness, pseudohypertrophy of the calf muscles, spinal deformity, cardiopulmonary involvement, and mild to moderate MR. Risk factors. DMD occurs primarily in males. However, it rarely occurs in females. Caused by genetic changes, DNA variants in the DMD gene. DMD is inherited in an X-linked recessive pattern and may occur in people who do not have a family history of DMD. How is it diagnosed? Diagnosis is based on symptoms, clinical exam, and the result of a biopsy to remove a small piece of muscle for examination. Genetic testing may also be done to confirm diagnosis. Medication and treatment. Prednisone helps by protecting muscle fibers from damage to the sarcolemma. Calcium and vitamin D help to prevent osteoporosis. Antidepressants may be prescribed if depression occurs. ACE inhibitors or beta blockers are used to help decrease the workload of the heart. Therapeutic management. Due to the fact that nearly all boys with DMD between the ages of 7 and 12 lose the ability to ambulate, aids will be necessary. Braces, orthosis, mobility and positioning aids will be needed. Surgical spinal fixation may be required by adolescents. Here is an example of the type of devices that may be used in assisting them with walking: the canes and the leg braces. Nursing interventions. You'll want to promote mobility, maintain cardiopulmonary function, and maximize quality of life. Patient education. The patient and the parents might need outside resources for help with care. Be there for the patient and the family. Sometimes support goes a long way. Teach parents how to monitor respiratory status. Also, teach parents how to use the adaptive devices and positioning techniques. You'll want to do this so that make sure that the child is using them correctly. Health promotion and maintenance. Perform passive stretching or strengthening exercises. Schedule activities during part of the day when the child has the most energy. Have the patient perform deep breathing exercises to strengthen and maintain respiratory muscles. Work with the family to develop a schedule for diversional activities that aid in appropriate developmental stimulation. There may come a time when walking is no longer possible. So when that happens, a motorized chair would be a great option, as shown in this picture. Here is a list of my references. Thank you for watching.